And we are going to start right now with my...
The broadcast is now starting. All attendees are in listen-only mode.
Take it away, guys. I got a child to deal with.
Okay.
Yay.
Hello, everyone. Welcome.
Hi, everybody.
We're going to
It's
give everyone a
exciting
few minutes to get in here.
I just realized I didn't open the questions thing. I need to. There we go.
I think we got Sylvia and Lori in the background, and we're going to be simulcasting this to Facebook and YouTube. So,
Whitney is number one. She's like our number one attendee of all webinars, and she's the first message that came through.
She jumped in there first.
Golf clap for Whitney.
Very good. So I can't believe it's June already, middle of June.
Well, everybody's logging in. Can we just mention some things that one, Laureen is now a blonde and she looks gorgeous. So this whole thing of her going south has changed her. You got a glow about you, and even your hair gives you a little halo look. And she was talking about how long my hair's gotten.
Yeah, it is. Yeah. My first 25 years of life, I had long hair like yours is right now and curly. I got the perm thing going. And then when I moved from New York to New Jersey, when I was a Jersey girl, at some point there, I cut it really short and red. Which is what most people, if they've known me through CCO, are used to. And then about a year and a half ago, I moved to Florida and decided to commemorate this new phase in my life that I would change my hair color. I couldn't go any shorter. Well, I did go shorter, but today I went to get a trim and she goes, "Do you want to go lighter?" I'm like, "How can I go any lighter?" She goes, "Platinum." I said, "Let's try it." So
well, I have to tell you that we went to one of the conferences one time, and somebody asked if you had to if you were going to work for CCO, did you have to have red hair? And it was kind of a thing. And
no,
or my hair doesn't look, or no hair. My hair doesn't look as red right now, but Jennifer, you look really red at the moment.
It looks really red, but it's not.
It's not.
It's kind of funny. It's brown, so it must just be the red shirt I'm wearing. I don't know.
There you go. It's that.
Gonna need a new camera.
Great glow.
Wow, and a new
people
camera.
are joining hot and heavy. I think it's slowed down. I think we got people in.
Yep.
I think you're good
All
to
right,
go.
well,
Yeah.
just
like
a little housekeeping to remember. You can hear us, but we can't hear you, so we have to rely on having you type your questions in the question box in GoToWebinar if you're joined with us there. And you can also type questions on Facebook Live and YouTube, and we're trying to consolidate all of them. At the end, we're going to answer whatever quickie questions we can that have come in, and we're going to try and monitor it. So I'm not going to be presenting any topics, but as Alicia and Jennifer are presenting their prepared topics, I'll be on trying to see if there's any questions that I can ask them live. So if you have something about what they're actually talking about, we'll try and get that in. So when you type to us, if we don't answer you right away, we're trying to get to all the questions. Don't think we're ignoring you. It's just the way that GoToWebinar works. Okay, I don't think I missed anything at that one. So we like to do polls. So if you're in our GoToMeeting format, we're going to launch our poll. Let me see, it's been a while here. So we want to know, how many webinars have you attended? That should pull up on your screen right now.
My answer is 99.9%.
We want to know if this is your first time. If it's a repeat time where you're back for more, like your first time back, 2 to 5, 5 to 10, or 10 plus.
Wow.
Boyd's been having fun with the polls, I can tell.
Yeah.
Back for more, repeat offender.
Yeah. Rachel says, this is my first time, and Carol Lee says, my first time. Wow. Yay.
Good. We love first timers. This is a great way for you to get to know us and our teaching style and our support style.
Whitney.
How'd you ladies hear about us?
Carol Lee's just excited I said her name right.
Where are we at? I'm trying to see what percentage.
Kathleen
Okay,
says
so
she's been with us since the start. Yoo-hoo, Kathleen, yeah.
all right, I'm going to close the poll in 5, 4, 3, 2, 1. And let's share the results. Wow, 35% first timers. I don't think we've
That's
good job.
hit that in a while, so that's
Yeah.
good.
Mhm.
9% have come back after one time. 19%, this is their second or fifth time. 14% their 5th to 10th time, and 24% are our frequent flyer. So great, that's a very nice mix. So you
Yeah.
first timers, you know, ask questions in the chat and we'll try and help you get acclimated. I also want to let you know if the best way to get help from us is to go to cco.us/helpdesk. We've got a dedicated help desk team that is really good at helping get people to where they need to go, make decisions on which course to pick and all that kind of good stuff. So take advantage of that. And they are on with us tonight behind the scenes, helping with the questions and on Facebook and YouTube. That's Lori and Sylvia. Thanks, ladies.
Close the poll.
There
Oh,
we
you
go.
did? Sorry, there's probably a delay on my end.
No, I was
No.
I was delayed.
Well, the last
I
couple just
forget.
found us through the internet, Googling and
Awesome.
surfing the web. So definitely
Great.
like and subscribe and spread
Mhm.
the word. So yeah.
All that good stuff. That's
Yeah.
really how we've grown. We've been doing these webinars for long time, and it was Boyd who asked me, well, why don't you do this once a month? I'm like, I don't know enough to talk about every month. He was, let them ask you questions, and I'm like, live? I got to know everything. Like, you know, he's no, they ask you ahead, and then you prepare. I'm like, oh, that I can do. So thank you, Boyd, and we're still doing it, and it's great. And we've built up how many videos on our YouTube channel now, Boyd?
Oh, I have that stat later down the bottom. It is
A lot.
1,259.
That's a lot.
Wow.
So that's a great resource to go to if you have a burning question you need answered right away. But if it's one you want to see us develop in the future and we haven't done before, or you feel like we need to do an updated one, on cco.us, there's a contact us page and you can put in your topic request and we vet them and get them researched for you. So today, the format is going to take us about 90 minutes to 2 hours total. We do our little intro like we're doing now, and then we have at the end a Q&A from the community. And so Alicia, why don't you tell us what questions that you've prepared for tonight?
Well, I have 3, and I noticed that when we were looking at the questions, one of the things that came up is these are a little more basic type questions than some that we've done in the past. I like to think of them kind of back to basics. So for our first-time users to this webinar, maybe that's good. I'm going to do sequencing codes, leveling table of risk for E&M, and coding for separate procedures.
All right, those look good. And Jennifer, what are you doing?
A particular CPT code of 96372, which is injections. So can that be done in the office? How do you and when do you code for history of an illness? And how do you combine all your credentials? So.
I'm interested in that one. And so just so you guys understand what they're doing with these questions, they're taking time to actually go in and develop them and do answer sheets and all of that. That's why I'm just here, just kind of hanging out. I didn't have to. They did a lot of work to prepare for this. So it's kind of like a nice little meal that they're hoping that you'll enjoy. So we normally will do those prepared Q&A questions first, and we do a drawing for prizes, and then we'll go through some of your chat questions. You can come and go whenever you want. We do have CEUs for our club members, but that takes a week or two to get everything processed in the club. So there's no live CEUs for this event. We don't do it that way anymore. We're all about people becoming our club members, and those are the folks where they get all the goodies like CEUs and stuff like that. You can ask a question anytime in the GoToWebinar question box or in Facebook and YouTube. And that's the link for the topic request that we were just talking about. So if you know you have one that's going to take time to develop, like we're going to have to do some research, then go ahead and put that on the topic request page. But if you have a quickie one that you think we can answer like in a minute or two, you can go ahead and put that in the chat box and we'll try and get to it later tonight.
Okay.
So this slide is to encourage you to stay to the end because we do a nice giveaway and you could win a Blitz video package or our phone session with one of us or a year of the CCO club at the basic level. So hopefully you'll win tonight. Okay, so these are about the CEU. So basically look for that. If you're a club member, look in the club in about a week or so and you should see the info there. Oh, this is the fun part. We get to go over people who have recently passed. We know things slow down a little bit in the summer, but we still have a lot of people that worked really hard. Our recent exam passers, these are, oh, we got a variety here. So Karen P. passed her CPC exam. And on the right-hand column, we're showing you what tools they use for those of you who are new.
Yeah.
For those of you who are new, you can see what kind of tools. We have full courses, we have review blitzes, we have practice exams. So the bottom line is that these people pass because of their hard work. They just use some of our tools, which we appreciate, and we like to acknowledge them. So we have Alicia Espinoza, got her CPMA, congratulations. And Raluca B got her CPB, the billing one. If, you ladies want to do this page?
Sure.
I can do, or you
I
want to
don't
do it, Jennifer?
see it yet. Well, I don't
Yeah,
see
mine,
it yet.
we got a little bit of a delay. I noticed
A
it.
bit of a
She's
delay, yeah.
Oh, okay.
Mine is still showing the
Yeah,
print.
there we
There
go.
it is.
Okay. Okay, so we have CPPM, which is your practice manager, Julia M. passed in March. Melinda Paulette Rivera got her COC. Lisa Rubalcado Smith got her CRC, as well as Christine Rodriguez.
Very good. We got quite the variety.
Mhm.
Okay, so those are, and now if you've passed recently, you want to put it in one of the chats, let us know. We'll give you a shout out. And please go to cco.us and in our contact us page, it's tell us you passed and just fill that out and then we'll have it in our database and you'll be on the next slide deck and just kind of get it memorialized. We like to give shout outs for that. All right, so are we ready to get into the prepared questions?
Yeah. I
All
think it's
Who's
do I
first?
get to go first? I always like going
Alicia
first.
gets to go first. So Jennifer and I
okay.
are going to
Okay.
drop off camera and
Well,
give her the floor.
let me read that while it's on the screen. Let's see. It says, I'm a student taking billing and coding at my community college, having trouble with sequencing. Any advice and suggestions? So I'm on a different computer, guys, than I normally am. Thus, the camera looks a little different and everything. So I'm going to keep leaning forward because it's a much smaller monitor than I'm used to. It's not that everything's small, but I'm just waiting for the other screen to come up. My delay is probably my internet. There she is. All right. And you know, this is really a common question for new students. I think probably one of the first major questions that we end up getting as instructors from the students, not just with ICD, but also with CPT. They it's pretty easy to look up a code once you learn how to look up. You know, I used to say it's like looking up a name in a phone book. Sequencing, though, now there's a catch to that. And a few key things that are going to help you with this. Now, I didn't spend a lot of time because, again, this person is already a student. They just want some additional help. And remember at the beginning, I said that we sometimes have some really intense topic requests that come in, but this is really back to basics. And I think it's good for some of us to do an overview again. So as that scrolled down, the things that I think are important to remember is one, that the sequencing ultimately is based on the disease process. So a disease that is more difficult to treat or maybe terminal versus something that is acute versus chronic, that happens to have a sequencing guideline. So again, a quick tip, anything that is acute is going to be sequenced first, then chronic, right? Because it's a sudden onset. That's the way the disease process works. If we are treating two diagnoses and one is more severe than the other one, of course, it's going to get sequenced first, but if both of them are being treated the same. The guidelines, very, very straightforward, and I don't want you to freak out because you really haven't gotten into maybe the individual chapters, both with CPT and with ICD, to get a feel for how the guidelines are repeated and used again in the individual chapters. So sequencing, say, fractures, multiple fractures, or anemia or something like that, when you get to those chapters, it's going to tell you how to do it, okay? And then the other thing is, even though you think you've got everything down, you know, you think, okay, these are the guidelines, this is always the way it works, there's always an exception to a rule, right? But there's so few of them that you can remember them. You can write them in your notebook and kind of go over them. You think, oh, wait a minute, I have to pay attention to this because I remember there's an exception to the rule. It's kind of like the A before E except after C, right? Except in, and then they like receive, and you know, it's like that. So with procedures, the first thing you need to remember is anything that's more complicated is going to go first. Now, this is one of the first things when you get into like the integumentary system for the body systems, when we're doing a repair and a removal of something. So we're going to remove a lesion from the skin. So I've got now let's say I've got it on my arm here, and I need, they're going to remove this lesion, and then they're going to have to repair or close that up because they're leaving a gaping hole in there for me, right? If the repair is more complicated or time consuming, just relatively more time consuming than the removal, it gets sequenced first. That's a basic guideline. The more complicated it is, the sequencing is prioritized. And I can't tell you how many times that a student will say, I don't know why I missed this question. They sequence the suturing of the repair in front of the removal, but that's not the order that they did it. It's because order doesn't necessarily carry any weight. It's the procedure and the complication. A little heads up on the body systems integumentary. Whenever you're reading a report and they're showing you layered repair, they're going to put stitches underneath and on top. I've got a lot of ways to explain this, and we've done those in those YouTube channels that we talked about. And in our individual courses, but you know, you can't close a wound like this. You have to close it like this. So those under sutures means it's more complicated, takes more time. It should be prioritized. It gets leaked first. Also, location, right? Sometimes if you have more than one area that has a wound that you're working on for integumentary system, you know, location can mean a priority. Next, for diagnoses. Now, by all means, diagnosis is my favorite. You'll learn this about me when you come to more of our webinars. I love diagnoses. The thing about diagnosis is the tabular tells you, again, it reiterates, and it does it by little hints next to the code that says code first or code in addition. Now, the guidelines at the front of your manual has all that information in there, but you're probably not going to remember. So let's say, for example, our patient has strep throat, right? And then it's going to say, oh, if you have, you know, the type of strep or the organism, you know, in addition, code that. And so then you go and you find that. When it says code in addition, it means it goes second. If it says code first, it literally goes first. So again, you'll see that in the notes, and that's why you're going to look at that in your manual the more you go through. Also, as we slide down the kind of exceptions to the rules, you see those a lot with the diagnosis codes, and the examples are pretty classic, and the ones that you'll see testing questions on, they're going to be for things like anemia and cancer. Okay, those are the two main exception to the rules, like the I before E. Now, what you have to remember is what makes the exception first. If we have a patient that has anemia due to their cancer, right, because of the type of cancer that they have, they've acquired anemia. That's going to be sequenced one way. The anemia may, or I'm not going to tell you which one, you have to go look it up. It may or may not go first, but it tells you which one is sequenced first. Versus anemia due to the cancer treatment. It's actually flipped, okay? And that is a classic exam question. You need to know the difference, the sequencing. Another sequencing that is pretty basic and you have to have under your hat, primary, secondary cancers, okay? Primary cancers usually go first if you're talking about primary and secondary cancer, but just because of when you got the cancer or when it was identified doesn't necessarily tell the sequencing. It's based on which cancer is being treated that day. So you could have a secondary cancer. I could have brain cancer and lung cancer. And if they're primary brain cancer, secondary lung cancer, if I'm being treated for secondary lung cancer, it'll always be called secondary lung cancer, then that's sequenced first, even though it's called secondary, okay? So it's little things like that, that verbiage, that once you've got that under your belt and you realize the verbiage, you understand the disease process, how the treatments and the disease work together, the guidelines are really only based on the disease process. That's how we know to use them. Then you're golden, all right? Really don't fret about this, guys. The guidelines, you're going to end up reading them multiple times. And as you go through your manuals and through your course, it's going to be an eye opener and you'll think, oh yes, that's why they said that. Oh, that's why this is sequenced this way. It's different. And again, it's all there. You don't have to really have this stuff memorized, but you do have to be aware of it. And the only way that you're going to be aware of it is to read it, jot it down in a notebook, make notes in your manuals. That's how our Blitz works with the CPT that we'll tell you more about later, but that's one of the big things that gives you an advantage. That's it, guys. It's a lot of fun and all the information's there. You just got to be aware of it.
Alicia, someone in the Facebook chat was asking about help with sequencing Z codes. Anything you can talk about real quick on that, or?
Yeah. Z codes usually are always sequenced last, unless, because there's always an exception, they're the reason for the encounter. So most of the time, Z codes are codes that are just describing what's going on. A Z code, I have a history of. A Z code, I also long-term insulin use. Those type of codes, they're always going to be sequenced secondary or last after your initial codes. However, you may have a Z code that's an encounter for a wellness visit, an encounter for, prophylactic treatment or something like that, encounter for an injection. Those would be sequenced first. But again, don't freak out, because the manual will tell you when it's an encounter. Whenever you see encounter in the code description on a Z code, it's going to be sequenced almost always first.
Very good.
Everything else is a descriptor. We got additional training in that in our YouTube videos, medical coding cert. So you can go in there and just type in Z code.
Yeah, someone was asking, maybe I'll just take a moment just to jump in and do that. So if you go to YouTube, let's see here.
It's pretty nice that while she's bringing that up, to be able to do that, she'll show you how to ask a question in there. And these videos go back like 8 years, guys. So
I'll get that ready for while you're doing the next question. I'll show them how to get to our YouTube channel and how to search it. Okay, let's see who's up next here.
Oh, let me change my camera.
All right, so today's June 20th. I had to check my dates. That's how bad I am. So we've got a 24-hour flash sale where you can get 25% off of our courses and blitzes, and you want to go to this link. Make sure you go to this link, not a regular sales page, or else you will not get the discount.
And this
So
is
that's
special just for the webinar attendees. Nobody else is getting this actually.
Oh, okay, good. I didn't even know that, see?
Yeah.
So cco.us/webinar sale. Okay, so this is something new, guys. So you're getting rewarded for attending with us. So make a note of that, and maybe we could share that in the
You bet.
various chats. Okay. What did I click on? Something I wasn't supposed to. All right, so Jennifer, it looks like you're going to be going next. And we'll switch the cameras, get you on. All right, you go ahead and read that and I'll get the answer sheet coming up.
Sure. For our, when is it appropriate to use 96372? I originally typed it in backwards when I started doing it. So in an office setting. So is it okay to use the modifier 25 when you do an E&M along with that same code? So we will go into what is a 96372 is what we'll start out with. So a 96372 is a therapeutic, prophylactic, or a diagnostic injection in which you have to specify the substance used or the drug used. And then it's administered either subcutaneously or intramuscular, because then you'll see there's other codes after that that are for different routes of different routes are used. So this is just subcutaneous and intramuscular. So in looking at CPT, some of the CPT guidelines, I wanted to stress them. They note some of these are what's noted after the code 96372, because then we'll also get into the guidelines of that they talk about prior to the code within that family of codes. So you're going to report 96372 when you have a anti-neoplastic hormonal therapy injection, because then you also have anti-neoplastic hormonal therapy injections, and that's going to be a different code. So when you're using the anti-neoplastic therapy injections, that's this code. If you're doing administration of a vaccine or a toxoid, you're going to use a totally different code. So don't confuse some of these here. That's why they're specifically stressing these in the CPT manual. And it specifically says, do not report this code for injections given without that direct physician or other qualified healthcare professional supervision. So you need to have the physician there when you're doing this, or you report the 99211. So it does say hospitals may report this code when the physician or other qualified healthcare professional is not present. So these can be used in a hospital as well as an office setting. Now I'll get into that in a little bit because there are some exceptions when you're talking about the hospital. And you're not going to use 96372 when you're talking about injections for the allergy, for the immunotherapy for your allergen injections. That's a totally different code. That's all its own code for the allergies. So it's breaking it down a little bit and giving you a little bit more information that this is used for certain types of injections. Now we hear injections a lot. Therapeutic, prophylactic, and diagnostic injection is what this type of injection is. So it's different than the 20,000 series injections, different from 60,000 series injections. So there's injections located all throughout the CPT manual. So you got to make sure you got the right kind of injection here. So when they talk about the guidelines for this family of codes, and the family of codes is 96365 through 96379. So those are all different kinds of codes. So a therapeutic, prophylactic, or diagnostic injection is for the administration of a substance or a drug. These services typically require direct supervision, for any or all purposes of patient assessment. Now that's a key word right there, is that patient assessment, because what typically happens in an office visit, the physician is assessing the patient. So that's going to play into some of our insurance coding reimbursements. So we want to make sure that we're talking separately identifiable when you include it with an office visit. So the purpose of the patient assessment, provision of consent, because this is a surgical procedure, this is a minor procedure that they need the consent from the patient prior to doing any of this. Safety oversight, making sure we're doing it properly, and the intra-service of supervision of staff. So making sure that everything is being done properly. So this is typically going to fall under that needing supervision. So these codes are not intended to be reported by the physician or other qualified healthcare professional in the facility setting. So 96372 is reported per injection. So no matter how many substances they put in one syringe, in one injection, they could mix two of them together perhaps. That's one injection, but you may have two J codes possibly when you're reporting the substances that were injected. So however, if more drugs are needed than what fit in that syringe, that's only one injection. So that they kind of spell that out a little bit, that just an example, I'm sure this doesn't really happen this way, but I was trying to give an example. You have to provide 6 milliliters of a substance to the patient, but you have a 5 milliliter syringe, right? So you're going to do 2 injections for that patient, but you're injecting 6 milliliters. So that's only done that one time, even though you had to break it up 3 and 3, 5 and 1, however you want to make 6. They was only injecting that 6 milliliters. So that's one injection. So these are remember, this category, you're going to find this category back by all of our hydrations and infusions and you know, when you get into some of the chemotherapy agents and such. So a subcutaneous infusion that lasts less than 15 minutes, you're going to use this code as well, 96372. So if it's a subcutaneous infusion lasting less than 15 minutes, we're going to use this injection code for injecting that substance into the patient. So when can you use a modifier 25 with the E&M? Now, of course, if the patient is scheduled to come in for this procedure, they've already determined that assessment. They've already consented with the patient. They've already done everything that there is supposed to be doing, and they said, okay, come back next week and have this injection performed. So you can't do an E&M with that. You can't do an evaluation and management service when it's already been scheduled. So you already have everything all done. Now they're just coming in for just the service. So you're not going to bill an E&M along with that. So if it's already scheduled, you're not going to bill the E&M. So if there's a separately identifiable service, you must have the supporting records for that medical necessity to have a separate service along with this injection. So even if it's already been scheduled. So some of this information I pulled from an AAPC blog, and there's a link there for that. One of the examples that was given is, say, they used OB-GYN services for this example. So they said, okay, patient's coming in for her Depo-Provera injection, right? She's already knows she's coming in for it. She's scheduled to come in at the time interval that she's supposed to have it done. So she comes in for that injection. That's the service she received. Now they had another example and said, well, say the patient comes in for a pelvic exam or has pelvic pain and comes in for an exam. And as they're looking over their, they're assessing the patient and they're looking over the record and they said, oh, wow, it's been a while. You haven't come in for your depot. Here, we can do that today. That's separately identifiable. They didn't come in for the Depo-Provera shot. They're having pelvic pain. They're being assessed to see what that problem is. But while they're there, they said, hey, you're here. We can go ahead and do this while you're here that day. So you could do an E&M in that scenario, but not in the first one because they were scheduled to come in for their Depo-Provera shot. Now, when we talk about payment, because that's what I love to do, is the billing side and the insurance, some carriers may not pay for this service, especially when you tie it with an E&M, even if you use the 25 modifier. So you have to make sure you're looking at the reason why they're coming in, and it has to be medically necessary. In order to do an E&M visit along with a procedure, it always has to be a separately identifiable service. So this is an example that I pulled off of United Healthcare. So all different carriers, I found all different kinds of carrier information out there, when they will pay for an office visit, when they won't pay for an office visit. So this one I thought it interesting because it says that family range of 96372 to 96379, they are not intended to be reported by the physician in a facility setting. So United Healthcare says, no, you can't do it in a facility setting. But you remember in the beginning when I looked over the CPT guidelines, it said this could be used in a facility setting without that supervision of the provider. So it depends. So it depends on your scenario, it depends on your insurance carrier. It's possible that service may not be paid and will be inclusive with another service that might have been given on the same day if this is their scenario. So it's always good to check your provider rules as well, especially if you are in the field of like GYN, and this is something you would do quite often. You want to make sure you're up to date on your rules. If you work for a facility who quite often does certain types of injections, or maybe those less than 15-minute infusions for some reason in some kind of setting that, outpatient type of diagnostic or other type of setting, you want to make sure you also look at your insurance carrier rules to see what they're going to do. In that case, you just might be billing an emergency room visit, and that will be eaten up with a charge for providing this injection service, would be along with your emergency room E&M charge that you've billed. So it's a little bit interesting. You can bill this code in an office, but whether it's with an E&M depends on what was medically necessary and what's documented in the medical records, of course.
Yay!
All right. I had to switch my microphone. Is this horrible, or can you hear me okay?
No,
You're
it's
okay.
good.
Yeah.
All right, cool. All right, so let's see. I am going to put my camera back on. Am I there? All right. So I wanted to show real quick in between here how to get on our YouTube channel. Can you guys see that okay?
Mm-hmm.
All right.
Moving
So
over.
what's really good about the YouTube channel, if you click on subscribe and you become one of our bells, click on the bell and you'll get email notified whenever we do this live. So I know for myself, I'm not on every webinar, but I know when Alicia or Jennifer is doing one with Boyd, because my Facebook goes off, my YouTube goes off. So, whatever's convenient for you, wherever you are, you can click on and join us. But basically, if you come here and you click on this magnifying glass, you can type in any search term. And if you like to see a video, you want to sit back and kind of listen to us, go ahead and type that in here. You can type in EKG. Let's see what comes up and see if we talked about that ever. Yep. So we've got several videos where we've somehow that phrase is in there. You can look at the titles to see if it's definitely what you want.
You can even look at dates too, right? You can see the date too.
Yeah, like
so
this one's
if
from
it's
6
something
years
that's
ago.
ICD,
Yeah.
yeah.
So like I said, some of these might be outdated, so you'll have to, look at the dates and take things accordingly. Another thing, if you want to search our website to see if we've had a blog article, is just to go to any search engine and just type in, I'm going to do EKG since we did that as an example, and do the site you want to search. So we're going to do cco.us. So it's site : and whatever the website is, you can put in the CMS website, AAPC, AHEMA, wherever you think you might want to find that information. But if you know you were on a webinar and you heard Alicia talk about something or Jennifer talk about something, you can come in here and chances are you'll find it. So you can see we've talked about EKG several times. And a lot of these will actually take you to a blog article where we've embedded the YouTube video. So that's where I normally start. When I said, I know we've done this before. I come here and do the search, and then I can share the link with whoever's asking the question. So we like to share that every webinar, teaching you how to fish. So there you go. Let's see, who is up next?
I think it's me.
Yes, but first, Boyd stuck
Go
this slide in to remind us to talk about, we have a reviews page on cco.us, and these are some of the more recent ones. So one from Lisa, she said, I think I just recognized her name from the recent graduates. Just got my results and I passed my CRC exam on the first try. I am now Lisa, CPC, CRC. I purchased the CRC course from CCO and reviewed the CRC Blitz videos twice and made notes, took my practice exam several times, and I passed. I'd taken another CRC course from another entity shortly after becoming newly certified and could not get the grasp of the concept for some reason. I knew I had to tackle this beast and conquer it, and now I can say I have. All thanks to CCO and their courses and review Blitz videos. Well, very nice. Thank you for that review. So at any rate, if you, for our newbies, the 35% of you that are on that, this is your first time, if you go to cco.us and you check out our testimonials page, you can see we get new ones put on every week, and you can get a really good feel for people's satisfaction level. So, you know, we have, oops, we have a different style. We like to think that we're kind of warm and fuzzy, like the you know, neighbor next door trying to teach our friend. So if that's the style you like, then hopefully you'll stick with us. You can also watch our YouTube videos and get a feel for how we teach concepts as well. Okay, next up. Oh, this looks like a long one. Alicia.
We have fun, guys. So I'm just waiting for the slide to come up. And there we go. Leveling table of risk. Okay, I'm going to read this really quickly, but it stated, when auditing an office note for a specialty, such as rheumatology, when it comes to medical decision making, our provider is under the impression that they would only use the presenting problem table and the table of risk to determine what level to use, normally resulting them in a high level of risk. My question for this section of the tab audit sheet for table of risk is, does all tabs, presenting problems, diagnostic procedure, order, and management options selected, have to be met to select the level of risk or no? Also, for number of diagnosis management options, new problems, additional workup, does that include a follow-up visit in a few weeks to a month? I thought this was only if patient was going to have a procedure or be admitted or transferred. So while that answer sheet is coming up, guys, what I did was I reached out to some people that I knew that were auditors. So they're already CPMAs. And I said, you know, I know how to answer this, but I want to know how would you answer this? You know, what opinion do you have on this? Because they probably have been asked this by providers. And so I wanted to get their perspective, and I'm wanted to give attribution or a shout out to both Teresa Mero and Barbara Cabuzzi, because they got back with me right away, and you can see their credentials here and get a little idea of their background. And one of the great things about coding is that you can reach out to people, like reaching out to CCO. If you have a question, you can join the club and just type us and we'll give you feedback. So with this type of thing is that, rest assured that when you pass your exam and you get out there, you're still going to have mentors and people helping you out. So I'm just waiting for the answer sheet to move up just a little bit. I think there's just a delay. Sorry about that, guys. Plus my screen's smaller. All right. So the first thing that I wanted to say is what Barbara had mentioned. I believe I put her first, and it was pretty cool. I went ahead and put what she had sent me in quotes directly from her, because she kind of summed it up quickly. So I wanted to highlight what she says, and then what Teresa says. She kind of spells it out with some examples. But with Barbara, ultimately what she's telling us is that when you are looking at that table of risk, and I'll show you here in just a minute, you only have to have that one, just like you said the provider was thinking. Yeah, they only have to have the one, because when the doctor, the coder, or even the auditor comes back and looks at that, they get to pick which best tells the story. All right. Which is the reason, or as Barbara says, reflects the encounter. Okay. That's really key. And they can have more than one thing going on, but which is the best, right? And the provider is going to be the best one to tell you with that. Now, as far as additional workup, yeah, that gets a little fuzzy. I understand. But it doesn't, like Barbara says, it doesn't mean a follow-up visit unless, and here's the key, a procedure has to be done. And that she gives a list. These are the things. You can do a test, and you can do even asking for records. You can do blood work. Maybe it's looking at radiology or having radiology done. Maybe you just have to go look into the actual problem to get a more narrow focus of what's going on. Maybe it's a condition that provider hasn't seen before. I was just watching a video like that for a pediatrician, and it was something really, really unique. And what struck me that he said was, your patient or the parents become the experts a lot of the time, because they go out and study and they say, this is where they found this or that. It was a rare condition where heteroxygy or something like that, where organs are flipped in the body when the baby's born. Not all of them, but anyway, don't get me sidetracked. So Teresa goes on to explain kind of the same thing, but in a little different way. She said, yes, you only need one of the three. So that answers the first question, but it has to cover the overall risk of what's going on with the patient. Now, she gives an example, and she says, okay, if you have a chronic illness and then there's an exacerbation with it. So let's say our patient has COPD and they have a severe exacerbation, then again, we're going to look at the side effects of that, and look at the column that she gave me permission to look at this. So number of diagnoses and managements, new problem. You get 3 for that, 3 points, right? So it's new problem, but no additional workup planned, right? Again, maybe it's an exacerbation, an asthma exacerbation with COPD. They already know what it is. They already know that the patient's had this before. But it's new. It's an exacerbation, but they're going to say, okay, this worked last time. We're good. Now, if we scroll down a little bit more, we're going to see that the amount of complexity or data reviewed, again, example, x-ray ordered or reviewed, regardless of how many there were ordered. So maybe we did several views of a chest x-ray, a front, lateral, et cetera, or several views of a foot because we may have a fracture or something like that. It doesn't matter. They just have to review. Okay. And then as we scroll down, she circled again. She did this with her computer, by the way, which was really nice. That's why I asked her if I could have permission to grab these when she sent them to me. It's like, oh, this is good stuff. I don't think I could do that with my mouse. so moving down to that table of risk. Okay, now that we've got that out of the way, let's look at that table of risk, because that's really what the question was about, right? The table of risk. And my view hasn't scrolled down yet. It's because I'm so far away in Texas, right?
No, it's not you. It's your computer, I think.
I know.
Yeah. Or something.
But
or
but
internet.
that's a funny thing, right? That's to say that.
It's
All right,
the
so
Florida connection.
okay, yeah. Oh, it's the heat in both of our states. Okay, so looking at the level of risk, and I can't see all of it yet, but I think she did this one in yellow, and to signify high, right? And I don't know how well you can see this, but you'll see this in the handout, the printout, and this is a regular table of risk, so you can just reference your table of risk. Here we go. Nope, she circled it in red. These are all of the things that make it applicable. All right, now that's something that new coders struggle with. Well, all of us struggle with, actually. This is what's applicable to those conditions. Doesn't mean you have to meet every single one of those, right? Now, as we scroll down some more, I think we've got one more table to kind of look at. If I remember correctly, there it goes. And again, special thanks to both of our coders. When she mentioned that, okay, we got a new problem, we did additional workup, or we're planning to do additional workup, this would be a new problem to that provider, right? Now, what did I mention before? I said, okay, we had COPD and the person has an asthma exacerbation. Maybe the person's, like I said, had asthma exacerbation before. It's a new problem for that patient for this encounter, but they've dealt with it before, versus this is a new problem. The patient's never had that type of a condition before. So again, the provider has to think, what kind of medication do I need to get? What's the patient allergic to? What works best with these comorbidities? What can I give and not give? You know, do I want to give very much prednisone to a person that has a condition with their lungs when they also have uncontrolled diabetes or brittle diabetes? Ooh, you know, and so again, that raises that list. It could not be selected in the follow-up unless the patient saw a different provider, or if the additional workup is including diagnostic tests and stuff like that. So again, that kind of sums everything up. Notice that she circled that with this, you just have to have the one. So again, we've got moderate, and because like with all that stuff, we have to meet and exceed, right? All right, so that wraps it up. This is really fun stuff to work with not just auditing, but auditors tend to be the experts in this. This is stuff we need to know anyway as coders. And then we check in with our auditors who experience and see a lot of it to follow up and think if we're on the right page.
Good job. And someone in the chat, one of the chats had asked about where do you find this table of risk? So I'm going to show that trick again. If you go to table of risk.
CMS?
Yes, I'm going to do table of risk. That's my phrase. And then I'm going to type in what site do I want to search, SITE, and then cms.gov. This is so cool because sometimes it's very hard to search the CMS website. So when you do this, it's going to give you a couple of hits. I did it while she was talking, so I checked it out first. So here's a link, and if you're in our club, we have a great E&M training by Maggie Mack. She's really good. She's a great auditor, and it happened to be in Boyd's hometown at the time in Tampa, and we have a really nice recording, and that's available for our club members. And in this, she said, this document here, I'm going to click on this right now, is like the Bible for E&M. This is what you really need to study and understand for the auditing exams and any of the E&M exams. So let's see that. Oh, here it is. So it's a PDF and you can download it. So now once I got here, I'm just going to do like Control F. You can do that on any browser, any document for that matter. It should work. And then it jumped me down. There's 5 hits. So it took me to the first of 5 hits on this PDF. And here's that same table of risk that Alicia was showing in her slide. So this is where you can go and find the official documentation on the CMS website for you to educate yourself, educate your providers, that sort of thing. So I thought you'd like to see how to get that.
It's cool stuff.
Yeah, and then there's some other hits to check out, like, okay, it's referenced in these 1997 documentation guidelines, and, you know, just some other things that you can check out, and here's the 95 guidelines, okay?
So coders are full-time researchers, and anytime that you can shave off a few minutes on doing that research, this stuff makes a huge difference in being productive.
And a lot of times when you're answering questions on forums or at work, you know, having a source to back up your position is really critical. So that's a good way to be able to go get that.
Makes you the authority if you do that. Just saying.
Okay, we have a poll coming up. Which area do you feel you need more education in? Oh, I like that one. Let me find it. Where's my poll?
While you're doing that, which search engine are you using? Somebody asked.
Well, I switched recently. I'm using, what's it called? DuckDuckGo.
Yes.
I kind of heard like Google was like spying on what you look at and stuff like that. So it was recommended somewhere to try that. And that's what I use. It seems to be working pretty good. Yeah. All right, I'm launching the poll now.
That's why it looked different. You probably didn't recognize it.
Yeah. They all work the same though. That's one thing I learned when I switched to that. I said, oh, is my trick gonna work where I, you know, do that searching? And it does. It works in Safari, it works in Chrome.
So,
all right, so
while you guys are doing that, real quick, this question came up from Karen. Will you be offering some new specialty training and stuff? And you know, it's great. There's a suggestion place to put that in, but it takes a while to do a new specialty because we have to become experts or find experts to do that. So please let us know which ones you're interested in.
all right, let's see, how many do we have? Come on, guys, we only have 52 voted. Let's go. What areas do you feel you need more education in? This is where
They're
we
all
make
looking
sure
at
you're still with
DuckDuckGo.
us. Oh, yeah. Billing, CPT, ICD, specialty credentials, and other. If you pick other or a specialty credential, just tell us in the question box what one in particular you're interested in.
Oh,
all right.
OBGYN, general
Oh,
surgery.
Good. People woke up. They put their cookie down and ran and gave us an answer. Okay, I'm going to close the poll and let's see. Oh, very good. Everyone's running in now.
We got some good. Thanks for those suggestions, guys. We're typing them in. Oh, wow.
Yes. So 33% CPT, 26 billing. Okay.
Wow. Jennifer's our billing specialist, so
Good.
yeah.
She's like, yeah. And
Yeah, she loves this stuff.
ICD and 19% specialty and 2% other. And people are filling up the chat. We see OBGYN is a popular one, CPMA, general surgery, cardiothoracic. All right, very good. Thanks for sharing that. Hide results, okay.
Yeah. I want to take off my camera because I suspect that Jennifer's next. I like this going every other one.
Keeps it changing for the people watching.
Let's see here. I gotta move my stuff around here. Hold on. Okay. So this person just completed an AAPC medical coding course, and they were confused about when you should not code history of illness. So they have to make the assumption to code it, even though it wasn't pertinent to that present illness and the reason for the encounter. So can we review when it should be coded? So I had something in my head right when I thought of that and it jumped right out. So let's take a look at the answer sheet. So wait for it to come up. Just remember in those courses when we learn things, a lot of all that information is coming from guidelines. So it's usually stated somewhere where we receive our information from, whether it's from a CMS site or whether it's from the CPT or ICD-10. So this information usually is somewhere noted. So this is what we're going to go over, is where you can find the majority of this information.
That took a long time. Sorry.
Yeah, I still don't see it, so I don't know if everybody else doesn't see it either.
Nope, I don't yet, but it's I can see.
Yeah.
There it
Okay.
is.
Yeah. So, and oh, that's what I was going to say. So another thing to remember is, what's everybody using right now? EHRs. And so EHRs are very popular, and we've all heard this term, and if you haven't, you're gonna hear it, is cloning. So either they are forwarding all the information from one note to the next, or it is, you know, cut and paste, something like that. So a lot of times things that are noted in the medical record may not always be pertinent as well. So it gets a little bit difficult now with all the EHR systems and you know, people trying to do so easy methods, and especially now with some of the changes coming about from Medicare in the next couple of years, is going to be what is it, less paperwork initiative or incentive or whatever they're calling it, patient care over paperwork, trying to get away from the actual basing our leveling off of the documentation, and they want to base it off of the patient and their care provided in the actual experience that the patient had, versus can we check all these boxes and make sure we did everything to get the highest level code. So a lot of this information about history of illness is going to come from the Z section. So chapter 21, the last chapter in our ICD-10. So we talked a little bit earlier, Alicia touched on some of this, you know, our encounters for and stuff. Well, this is also where you're going to find your family illness, your history of illness, and history of personal illness. So factors that influence the health status and contact with health services. That's our Z chapter. So these codes are used in a setting, in any setting. So you can have them in the inpatient, you can have them outpatient. Somebody did ask a question about that it's sequenced different. It is sequenced different inpatiently, but you can use them in any setting. So they could be first or secondary codes. They could be primary or secondary or tertiary, or we have 12 lines for diagnoses. So it could be anywhere on there. It depends upon the reason for the encounter. And that's what Alicia was trying to touch on earlier. Some of those encounter fours, if that's the reason for the visit, the reason for the encounter. So when people say history, we got to make sure that we're using the correct terms here and that we're all on the same page. So, you know, especially when you're dealing in an office that's had people that have been doing this for 20 years and somebody's been only doing it for 1 year, so that we may use different terms. EHR, EMR, everybody's kind of agreed that they're all the same thing, but they're really not. So there's different types of history. A status code, people might think that's history, because status indicates that they are a carrier or they're like a sequela, the residual disease or condition. So they had a hip replacement. So now they have an artificial hip. Is that a history of? So it gets a little confusing sometimes, but a status code is distinct from a history code, as a history code indicates the patient no longer has those conditions. If your status post hip surgery, you're going to have that artificial hip, even if you need another artificial hip later, 20 years down the road. So you're always, it's not that you no longer have that condition with a status code. And they have it, that specifically says that as well in ICD-10. So the examples of a status code is Z21, asymptomatic HIV infection status. Are they ever going to get rid of that HIV? Blood type. You're always going to have the same blood type. Z74.01, bed confinement status. You're probably going to be confined to a bed for some time, possibly the rest of your life. Depends on the condition. So some of these, that's a status code. So that's not necessarily what we mean by history. So history codes, they indicate either a personal history or a family history. So a personal history code is indicating that that medical condition no longer exists and the patient is no longer receiving any kind of treatment. But they have a potential to reoccur. You know, when you have a cancer status, you're no longer treating it, you no longer have cancer, but it is potential to have cancer again. There's potential to reoccur or may need continued monitoring. So, but those can be used with follow-up codes. So if you're coming in for a follow-up of this problem, you can use the personal history code in the Z section. Now, family history indicates that a family member has had that disease or that condition, and that puts the patient at a higher risk for contracting that disease. So if diabetes runs in your family, you are, of course, at a higher risk for contracting diabetes. So they can be used in conjunction with the screening code to explain why you're having that test. If you have a family history of breast cancer and you're going to have one of the BRCA tests done or some kind of biopsy or something, then that's your family history. You're at a higher risk, so we need to perform this test that's proving your medical necessity. So you're going to indicate that family history code. Family histories can also be used on any medical record, regardless of the reason for the visit. So really, it does get a little bit confusing, but we need to look at the reason for the encounter. So typically, when we look at ICD-10 codes, do you know that there's more than one section of guidelines? So typically, when we look at these guidelines, pretty much everybody only looks in section 1. Well, there's actually 4 sections. So each of them deal with something different. Now, section 4 describes outpatient services assignment of secondary codes. So remember when it says list this first, or these, we know which one to do first, but now what do we do for our secondary codes? So under J, code all documented conditions that coexist. That's the title of category J. So it mentions to code all the documented conditions that coexist at the time of the encounter or at that visit and require or affect that patient's care or treatment or management. So something that's requiring a service to be done, you're going to use one of those coexisting, one of those codes to indicate why you're doing this service, or if it's going to affect the type of management you're going to do, the type of procedures you're going to do. We don't want to provide this certain medication because of a family history or personal history. So that's a secondary code, that family history or personal history. We're not going to encode conditions that were previously treated and no longer exist. So do not code those conditions that previously existed and they're not being treated anymore, okay? However, the history, and I'm sorry, that's supposed to be a Z80 and a Z87, not an X. I guess my finger didn't go over far enough when I typed. May be used as secondary codes if this condition or family history has an impact on their current care. or influences their treatment. So if it's going to have an impact on that care, then we can use those codes as a secondary or tertiary, depends on how, what all they're being seen for. Now, AHIMA did have an article regarding this, and I did post a link there for AHIMA. So they suggest kind of reviewing some questions. Ask these questions first. Does that condition currently exist, or has it been resolved, but it's just included in the medical record? So if it currently exists, if they still have that condition, then you may need to code it. But if it doesn't exist anymore, or it's been resolved, but they just are cutting and pasting this information, they're just cloning everything, it just automatically pulls everything into the medical record, that's possible. That doesn't mean the patient still has it. That's a flaw with the EHR system. So that's, we need to ask that question. Does it currently exist? Or is it just included in the medical record? Did they just copy everything over for the past 20 years? I mean, our system goes back 25 years. So we could have something that a patient had when they were 3 still pull over into their current condition. Is a current condition that is being treated, or is it affecting the care and the management of what you're treating? So that's a question to ask if you're going to code it. Is this a chronic condition receiving ongoing care or treatment? Because chronic conditions is another category in Section 4, coding chronic conditions. So that's something to look at, is the guidelines for chronic conditions. So a question to ask, is this a chronic condition? Or does this history or status impact their current care? So some of the questions to look at, to review when trying to extract information and code that diagnosis as well. Now this is something that took this question to mean an outpatient setting, and because I know risk management, you're looking at a little bit different, and I know Alicia can speak a little bit more to that if there's something that we need to add about that. When you're talking your risk assessment and your risk management coding, that's different than what we would be coding in this scenario. Are we trying to include a personal history or family history of a condition? So remember, review these guidelines, highlight them, mark them, go to the Z section and write in red pen, go look at the guidelines. Anything to draw your attention to looking up the guidelines, especially when you're taking an exam and they'll try and trick you on there. Is that diagnosis that they had in the past, is that currently being treated, or did it get resolved? So one of the answers might include the family history of or personal history of a disease, but is it actively being treated? So.
Very good. Thank you. Thank you.
Mm-hmm.
Alicia's back.
I have to make sure I unmute myself.
And this link here, hopefully we'll share in some of the chats. If you could take this survey for us and let us know how we're doing on these webinars. Let's see if I can grab it here. Oh, one more try. Copy link address. There we go. And I'm going to put that in for YouTube because it's hard to share links there. There we go. Yeah. Nope, didn't work for me. All right, I'll let Boyd help us with that. Okay, next up is Alicia.
Hey. This was an interesting one. How do we apply the instructions and the guidelines in the CPT regarding a separate procedure? Another really frequently asked question for new coders, but even us who have been coding for a while, we'll come up and look at this and we'll think, oh, wait, no, what were we supposed to do? The guidelines don't really change, but whenever we look, the verbiage for the documentation, everybody says it a little bit different and everything. So I kind of did a quick overview. So again, kind of back to the basics for us. And the first thing that you need to tell yourself is, you know, do I know the modifiers? The main modifier, which actually kind of describes a separate procedure, is 59. So that is the distinct procedural service. And people sometimes are intimidated with modifiers. We have some great training on our modifiers, but let's do a quick overview. The thing about modifier 59 is it has to be a non-E&M. All right, now you can just read this all. It's all over your manual, and you can Google it and everything. But the key for 59 is it's non-E&M, because we have another modifier if it's an E&M. It's like 25, and the other key is it's not normally reported together. You know, I keep saying again and again, it's all about the disease process, which when you have a disease process, you have common procedures to treat a disease process. And there's policies and procedures in the way we do things. So if it's commonly done together, then it's not going to get paid out or be reported separately. Right? That's just something to keep in the back of your head. Okay. So the more you become aware of the way procedures are done and scheduled, that'll get easier for you. So again, has to be a distinct, independent. It's got to be non-E&M, and it's not normally reported together. I got some examples for us that'll help you though. Also, documentation must support that it's either a different session, or maybe we did a different procedure or surgery. And again, I'm not going to read all these because I bulleted them for you. So again, this is the description that comes with modifier 59. You can find this in your CPT manual. There's a section for modifiers in one of the appendixes. I can't remember which appendix it is off the top of my head real quickly, but I bet if you guys tell everybody in the chat, they're like, boom, 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 you're screaming at me right now. I can tell. I know it's not Appendix L, because that's the heart and stuff. Okay, so as we scroll down, I bulleted these things that you have to ask yourself to allow you to be able to code something as a separate procedure. And that's really what the guidelines are going to tell you as well. Let's see. And another thing is, my brain works maybe like yours, I don't know, but I abstract quick. You know, I learned how to speed read. So if I can like tell myself stuff in a bullet format versus reading it in a paragraph, makes a big difference. So the first thing, ask yourself, is it a different session? Is it a different procedure or surgery? Okay. Is it a different site or organ system? This is a biggie. I think you see this one a lot. Separate incision or excision. That's very important. Separate lesion or separate injury. But with separate injury, think of this. If the injury is extensive injury, so I gave an example of like a motor vehicle accident. Hey, you got a lot of stuff going on there, right? Now, we wrap this all up when we talk about separate procedures in, you got to check your NCCI edits. If you don't know what an NCCI edit is, I put at the end of this answer sheet, I footnoted a document that you can go look at that explains some of the NCCI edits and how to read them. Right. And then, so I just put the kind of the title, which is very, very long, but that'll be very helpful. I use Find a Code all the time, and they have the NCCI edits. NCCI edits ultimately will tell you if you can put two codes together and bill it out, or you can't. It's very simple. That's what that does. So our examples, as we scroll back up, yes, examples. Let's go over those really quickly. So this is one I saw from another website that had kind of answered the same question. They had said, if we're going to I don't say that, lysase, or we're going to cut some adhesions followed by a colectomy. Now, the thing here is it's the same anatomical area. And quite honestly, your abdomen, your whole body has adhesions all around it, because our organs, even though they're packed in tight, they're not all floating around, right? They're packed in tight. And so there's adhesions holding them together that are just natural. And then there's adhesions that build up due to things like endometriosis or scar tissue that connects things that maybe shouldn't necessarily be connected in that way. Ultimately, when they're going to go in, even if they do a laparotomy, sometimes they have to go in there and cut those adhesions to get in and look at what they're doing. So you don't get paid extra for that. You don't code out extra for that. You don't code a laparotomy with a colectomy either, because it's just a given. We're going to go look around. That's what a laparotomy is. We're going to go look around till we see the organ, and then we're going to look around and make sure there's nothing else going on when we get in there. Next, appendectomy and a cholecystectomy, same setting. Same setting, but two different surgeries, two different organs. And it's relatively common that if a person has a appendectomy or they have appendicitis, they'll go check the gallbladder. And a lot of times they'll have you sign consent forms ahead of time that says, hey, we're going to go in and take out your gallbladder. At the same time, we're going to look at your appendix. And if it's anyway bad, we'll just go ahead and remove it for you at the same time. There's no sense in going in and doing this twice. Now, if they go in and look at your appendix and there's nothing wrong with them, they're leaving it alone. Right. But let's say they go in there and they take out your gallbladder and they like, ooh, you know what? That appendix is kind of inflamed. It's enlarged. I think that's going to be a problem. Let's go ahead and we got permission. We're going to go ahead and take it. Two separate, right? All right. So that was separate procedures. Here's one you may not have thought of: hysterosalpingogram, and it's actually a hysterosalpingogram, because oof is your ovary. That's easy to remember, but you got two of them. And so what we're doing is they're going to go in, they're going to remove the uterus, they're going to remove the fallopian tubes, and they're going to remove the ovaries. Can they go in and just take out the ovaries? Yes. Can they go in and just take out the uterus? Yes. Can they go in and take out the fallopian tubes? Absolutely. Will they commonly take all of them at once? Yeah. If they have a reason to do so, they're probably not necessarily going to take those ovaries unless you're really close to menopause, because we need that. We want to keep you as a nice female. You get kind of angry and grumpy if you don't have pills if they take those ovaries. But the key is, this is same organ system, right? Same organ system, but what? Separate procedures? Yes, but it's the same organ system. So actually there's a code for taking out and doing a hysterosalpingogram. That's one of the first things I learned to say in the medical school. So that's fun. How about cesarean section, single live born with tubal ligation surgery? Different surgery, right? Often plan to do at the same time. My daughter just had her 5th child in 5 years. She didn't have a C-section, but if she did, she might have considered, go in and have that tubal ligation. That's something that's commonly done together. However, it's a different procedure, right? Even though it's commonly done together and you're working kind of with the same organ system, it's a different surgery. Debridement of a wound on a left hip and BKA right. Now, if you don't know what a BKA is, that's a below the knee amputation. And notice here, following an MVA. So if that's a moving vehicle accident, then, okay, that poor guy's pretty messed up, right? Or gal, whoever. But different surgery, extensive injuries, different site, left and right. So yes, you're going to be doing separate procedures for that one, right? Okay. Last, I think we've got a lobectomy with biopsy. Okay, now this gets people because they think, a lobectomy, we're going to take out a portion of the lung. If you didn't know your anatomy, your one lung has 2 lobes and your other lung has 3 lobes. And sometimes if there is a problem, they can take out the entire lung. they could take out both lungs and do a bilateral lung replacement, but they might just take out a portion of a lobe, and maybe they would do that due to a cancer, and so they would do a biopsy. But see, they're not doing the biopsy and then doing a lobectomy because the biopsy needs to. No, they're taking the lobectomy, sending it out to path, and doing a biopsy. Same organ, same surgery. So you got to think about that, right? It's not a separate procedure. It's commonly done together. How are you going to know if these are things that are commonly done together if your medical knowledge on procedures or terminology, verbiage, and stuff like that isn't quite there yet, which is even common for some of us? If at the very last slide here, I added that link for you, but I also added this, some statements that are directly from Blue Cross Blue Shield, actually, as they were explaining to providers how they will pay for separate procedures and some of their policies and guidelines. Just because they say it's their policies and guidelines doesn't mean that's what the coding guidelines are, okay? But I just added that so that you could look at that verbiage. I also put a link there, so when you get your, you download the handout, or if you're in the club, you can go and hit those or look at those links. It's always a good idea to look at how the payers want to do something, because again, if it's for paying purposes, you know, you got to do what they say, or you don't get reimbursed. But we code for statistical purposes, and it just happens to be a convenient way to get paid. So we want to make statistically accurate coding, and that be our first thing we think about, and then being reimbursed. So other modifiers that you want to be aware of when you're dealing with that would be things like modifier 51, modifier 50, and also modifier 25, which would be E&M, doing separate things with an E&M. And then I think, and modifier 59. One other thing that you notice when you look at modifier 59, just to wrap up, is that if another modifier is more applicable, then you want to use that modifier. This is the title of the document, the PDF that came from CMS.gov. And actually, I think this was from like 2014. But again, it really worded everything very, very well. I think it was about 14 pages, and it explained how to use those NCCI edits. So you might want to, National Correct Coding Initiatives, and that might be helpful for you. So I just added that to wrap up. Fun stuff, guys.
And don't forget all those modifiers that would be more relevant are your X modifiers.
Oh yeah, I forgot to
XP,
mention.
XS, XU, XP, those are more relevant than a 59. So if those fit the bill better, then you have to use one of those.
And that is another whole topic that Jennifer has done a education on already in our club, and you can probably get some of that in the YouTube videos too as well.
It's one of my topic requests for regionals.
Yeah,
is the X modifiers. So
yeah,
we'll see which one they pick.
So speaking of the club, Alicia, you want to talk a little bit about why people should join the club? I think.
Oh, absolutely.
Briefly.
So, briefly. Okay, very, very quickly. The thing about the club is that, one, you know, we talk about CEUs and everything. I think regarding earning CEUs, our CEUs are relevant to the topics that you have requested. They're unique, and honestly, they're lively and fun. So if that's something that you would like to know, you can get a lot of CEUs in just joining the club. Webinars and support calls and stuff like that, we do that through the clubs, but we do live webinars all week long. And again, told you about the bell, we'll tell you, but if you're in the club, you are our primary supporter, and you guys know ahead of time what we're going to talk about. Maybe you have questions and you can actually put them in the club, especially like billing questions. You know, Jennifer's our expert, and I know she checks frequently. And in fact, if we see a question in there and we know that it's billing, we're already saying, hey, heads up, Jennifer, by the way, that's a billing one. Or maybe if it's a diagnosis one, they're saying, hey, did you go look at that one? Risk adjustment or something. Also, all of our products, when you order anything or you're part of our CCO family, we really go directly to our club members first. They get priority and extended support from us. We know who well, we don't know who all of you are by name, but you know, in the beginning, maybe we did. Now there's too many of you, but you have access to us unlike anybody else. Okay. We always go to our club members first. Was that fast enough?
Yes, but I did want to say about that extended product support. I don't know if I take courses, you know, on nutrition or different things that are personal interest to me, and a lot of times you have to do it within a certain time period, and then you lose it. And so when you first log in, you're like trying to download and save everything. With the club, you don't have to do that. As long as you're a club member, anything you've ever purchased with us, unless it's, you know, totally expired, you have access to. So if you become someone who takes a say physician-based coding course, like you're preparing for the CPC or one of those type of ones, you could get your credential, but then we update it every year, and you might want to come back. Maybe you end up working in radiology, and you're like, I wonder what the latest way they're teaching radiology. So you can log in, look at it. You might find a corresponding CEU quiz that goes along with what you just learned. So those are kind of the advantages. So you're building up this library. We even have a Prime club level for those who have already taken a course with us, one course. Now they want to take another and another. We have a lot of people that do that. So now we have a whole new level to our club for our Prime members that allow them to take the next course and the next course, and they don't have to pay an additional fee. They're paying that.
They get to keep it forever,
yeah.
right? As long as they stay a club member.
Yeah. So check that out. There's a whole lot more. We have a whole nother video on that. Go to cco.us/club. So it's all about the club. All right. I think this is our last prepared question.
Yeah.
Oh, good.
Take it away. Our last question is dealing with credentialing. So multiple credentials. This was kind of a little bit lengthy, but I kind of broke it down a little bit. So they have their RHIT from AHIMA with coding experience in the emergency room and ancillary coding. So she wants to be a complete coder with a much larger list of coding areas to cover. So AAPC, of course, does outpatient, inpatient, and specialty. AHIMA seems to offer two. They have a couple, but it kind of depends on what you're looking at. Would it be to an advantage to acquire AAPC certifications as well as AHIMA certifications? So if that makes sense to get credentials from both organizations, how should I display them? And then can I be a member of both organizations? So actually, I kind of did this a couple different ways. So once we get the handout pulled up, but I, of course, love each of us here, I think, has an alphabet soup behind our name, and that's actually, if you Google a lot of things, that's what they call it as well, as alphabet soup. So has a lot of things, areas of learning is kind of what I like to look at it as. So skill base, a lot of different ways to get out there. So I love achieving more certifications. I actually have 2 more to go. I just found out I have to do an AHIMA as well. So I'm going to have to join AHIMA as well. I have AAPC, and I'd also like to join AMBA. So there are a lot of different organizations out there. It just depends on what you want to do. So there's no limit to the amount of education that you can obtain. So if you just want to learn things, you can go ahead and learn them, but that doesn't necessarily mean you have to get a certification in them. So It's to your advantage if there's various specialties that you work with, or you want to expand your knowledge base. So if there's more things you want to learn, we talked about some of the AAPC specialties. So they have like E&M, family medicine, OBGYN. The one I'm getting is orthopedics. So there's you know, a lot of different specialties you could go in there, and orthopedics is an area I've been working in for 20 years. So that's one code that I'm going to add another credential. But there's so many different areas in AAPC. So we have like our auditor, compliance officer. So they're not necessarily just coding. So if there's more things you want to learn about the medical industry, then you could get more certifications that way, not specifically coding certifications. But this person has emergency room and ancillary, and you think about that, that's, you got to know pretty much everything for an emergency room. You family medicine types, you know, people get colds, you do severe injuries, you do debridements, they do all sorts of different things. You got to think your knowledge base already extends all of CPT pretty much. So what is it that you want to learn more about it? Being a complete coder doesn't always mean certifications, could just mean continuing education. You watch a lot of webinars. If there's a lot of things you like to do, attend conferences and go to workshops to learn more of something that just you want to know versus sitting down and taking that examination test. People can become a member of both organizations or multiple organizations. There's a lot of them out there. Some are, of course, our gold standards, our AAPC and AHIMA, but there are other organizations that do offer certifications as well. Something like AMBA, that's billing, and that's what I'd like to get into. They now do offer coder certification, but they started out as billing. So different organizations have different requirements, such as different due dates, due renewals. Possibly they have you renew your certification. Possibly in some of these organizations, AAPC doesn't have you renew your certification. You just have to do continuing education. And some of these organizations even accept CEUs from other organizations. So maybe you only receive partial credit or something, but information you learn from AAPC may still be relevant to AHIMA. So while AAPC does offer inpatient codings, we have to remember they're typically geared about outpatient, while AHIMA mainly deals more with our inpatient hospital organizations. So, you know, you can, depends on where your employment you want to go, depends on whether you'd want to get both. But just for people who don't know, an RHIT is a Registered Health Information Technician. That is one of the certifications that AHIMA offers. Now, this is pretty much, this is an equivalent to an associate's degree level of training in an HIM program. So a lot of community colleges might offer this as an option. And then you sit for this examination when you've completed that level of training. So your community college would have to be KHEM certified to be able to pass AHIMA. And there's more information on AHIMA's website on there about this. Now, the other one they offer is Registered Health Information Administrator, or HIA. That's a bachelor's level of training and education in an HIM program. So you can see how people who have sat for a CPC, that they have 6 or 8 weeks of training, and you know, 13 weeks, 16 weeks, however long it's been. Sometimes they're through a program at a college or something that's 8 weeks or, you know, 8 months long possibly. Where this RHIT and RHIA, those are much longer programs. So several professional organizations indicate a preferred level to list your credentials. It's like a typically you start off with your highest earned degree. So, and then you'd go down to licensing, state designation, if your state perhaps has some kind of credential that you work with, whether it's radiologist or RN or something, a national certification, and then awards. So when you're listing the certifications that you have, you start with your highest earned degree, You'd start with a degree and then you would move down. So I have a girlfriend, hers is MHA, and then she goes on to some of her other credentials that she has. So her master's in healthcare administration is first, and then she'll go down with some of her other credentials. So education degrees are always listed first, and they say because those aren't taken away from you. Under extreme circumstances, maybe they're taken away, but you list those first because those are ones you're going to be keeping, where a certification might be voluntary. So perhaps if you don't renew your membership with somebody, then maybe you would, you'd lose that credential or certification possibly. But maybe they're not always required for employment though. Multiple certifications. Alicia has multiple. I have multiple. Skylar has multiple. I know Laureen has multiple. So those can be listed in any order of relevance outside of your education to your employment. However, it's relevant to your employment or in the order that they were obtained. And they usually do the most recent one you got last. So it starts with the first one you got, and then it will go down from there. So CPC was the first one I had, then a CPB, then a CPMA, then CPPM. Now CPCI is a little bit different. I did get that in between there, but that's kind of a separate credential on its own as an instructor. So you leave that one towards the end. But on a resume, you list your relevant degrees for your career under education. And then your professional credentials are listed under professional certifications as a category on your resume. And I know that one of our live topics we did a couple weeks ago was about resumes. So only the credentials that are specialized for your career in relation to that job should be listed. So maybe you started in another field, in a totally electronic engineer. Maybe you're an engineer. Well, if you're now doing coding, then that's that you're not going to list your engineer certification behind your name. You're going to say maybe under education that you have an engineering degree. But only those relevant for your job, because that's indicating that you've had coursework and you've been tested. You have an examination, so that's showing that it's an industry recognized standard for that occupation that you have, like our coding credentials are. So there's a lot of various sites that I went to when I was looking, and this is just strictly dealing with a resume, that actually indicate that only if you hold a doctor level or a highly specialized credential do you include that after your name on the top of your resume. So I know a lot of people put on the top of their resume their name and then all their credentials, but so a lot of the top resume sites say specifically if you have a doctorate level or like an RN, you'd include that behind your name. So depends, it depends on what you see out there, depends on maybe how you feel, depends upon the job that you're going for. But maybe another resume site I looked at put it this way. Does the employer list the credential as a must-have? You have to have a CPC in order to apply for this job. Well, then you want that to stand out, because a typical resume sits on somebody's desk. I think the average is 9 seconds that they're actually looking at your resume. So you want that as behind your name. First off, if they say you have to have a CPC, then I want that CPC right behind my name. There's some that I've been looking at that say you have to have a master's and you have to have the CPCI. So once I get that master's next March, that's going to be behind my name with that CPCI in order to apply for that teaching job. So it just, I'm not going to list all of them, but I'll list what's most relevant. And another one says only list 2 credentials maximum. Because, and I like this quote, alphabet soup can convey a greater interest in training than in performance. So we know our jobs, we know we do a good job as a coder, and we know where to find the answers, and we know how to get them. And all those other credentials just say we know how to study. So if they're looking for our performance, we could indicate in a summary, we have multiple credentials, but which is our most relevant? And let's put those 2 up there first. But yet on the email, you want to do it a little bit differently. You don't put any abbreviations in there with periods. So your MBA is an MBA, not M period B period A period. And then you do your signature on multiple lines. So mine would look like Jennifer Sanders with my credentials. Then I'm an instructor for certification coaching organizations. So emails are a little bit different than resumes.
Very good.
Do you still have me?
Yeah, I can hear you.
Okay, because I said go. My thing says go to meeting stopped working. So.
Oh.
Oh, okay. At least you still got me. So.
Can you hear us, Alicia?
Yep.
Okay,
Yep.
good.
Everything's doing fine.
All right. But we're all here. So.
The party's still going. Yeah, so someone had asked about using like Bachelor of Science, like BS. Like I have a Bachelor of Science in Occupational Therapy, and I don't put that. I just put my coding credentials. But if I was, trying to get a contract or do consulting for maybe a rehab agency, then I might put that in there because I want to highlight that fact. So I guess if it's relevant, you could include it. You got to use your best judgment. It's not like the resume police are going to come after you, but.
Right. Yeah. Yeah, but you also don't want to distract from something
Right.
too. So you don't. Once I get more, I'm not going to put all 6, 7, 10 of them on the heading of my resume. I listed
You don't
under
want somebody to think that you're overqualified or you're going to ask too much money.
Yeah.
Okay.
I have a doctorate in basket weaving, but that's okay. I'm not going to charge you more.
All right, let's see. Oh, it's winter time. I think they've been working on our new system. If you guys saw when you signed up to fill out the form to see if you win one of these packages. So I don't know, Boyd, if you can help me out.
Yeah, we got a winner. I saw the name.
Do you know it? Can you share it with us?
As long as
Yeah.
Boyd's there.
Shoemaker is the last name.
Michelle
Hold on.
Shoemaker.
Michelle.
Shoemaker.
Michelle.
Come on down.
Because Shoemaker was a unique name. It's like, oh, I like that.
There you go. So Michelle,
There's a lot of them in my area.
You can choose a Blitz video package, a year of CCO Club Basic, or an hour session with Alicia, or I'm sure Jennifer would be willing to, and myself, anyone that you want. Even Boyd. We'll even put Boyd up there. So anything you want to know. So all you have to do is reach out to the help desk and tell them that you won and what you would like as your prize. So that's cco.us/helpdesk, and they'll help you out. So congratulations.
Yay. Maureen, we don't see your face, by the way.
Oops. Didn't mean to do that. I gotta, probably because I'm starting to look a little bit tired. My bedtime has gotten earlier here. I go to bed before my kids now. Okay, so just a reminder that CE certificate for our club members will be available in a few weeks. We've got a whole new process. And just to let you know, as club members, what people get is this whole thing is transcribed. We've got several, I think we have 3 or 4 transcriptionists transcribing all of our content that we do every week. And it's in a very nice, easy to read PDF. You've got the slide. We do share the slide deck with people who are attending in our GoToWebinar. They can get the slides there. But those answer sheets, that's really where the meat of everything is. Those are for our club members, and those are also included. So you have like a just picture of a single web page. You see the embedded video. You get all the documents. So it's very nice. It's definitely worth joining the club just for that. Because sometimes you want to listen to, I don't know if you're like me, I want to listen to YouTube videos and different things, and I got 3 started, and I'm like, oh, which one do I do? But when I really want to get to the answer, I like transcripts because I can do a search. I can do a keyword search and find just what I'm looking for. All right, well, what are we doing for time here? Wow, very good, 12 minutes left. So now we're going to go into answering questions from the chat. Jesus did want us to remind you again that tomorrow is the cutoff for the webinar attendee only special. And what was that website again? You guys remember? Was this
There is a
it?
slide there. If you just go down a couple towards the end.
Oh, I jumped
I
the
copied
gun.
it over. No, I copied the, yeah, but that's fine. You can talk
Oh,
about
thank
it.
you.
But it is there in the chat slide deck towards the end.
There we go. So behind the scenes, while we were jabberjawing here, Sylvia and Lori and Boyd helped compile the questions from our 3 different sources, our GoToWebinar chat, our Facebook stream, and our YouTube stream, and tried to pick out ones that they felt that we could answer relatively quickly. If we didn't get one of your questions that you put in the chat, please put it in as a topic request. Go to cco.us and /topic request and go ahead and put that in there, and hopefully we'll get to that in a future webinar. All right, so it looks like let me go to, where's that slide though? Should I do that now?
Yeah, so we don't run out of time. Yeah.
Yeah, just because I know some people tend to drop off at this point. So I just want to reiterate that flash sale, that's what word I was looking for, where you can get 25% off select courses and blitzes, is going to expire tomorrow, the 21st at midnight. So you want to go to cco.us/webinar sale. Let me try that. cco.us/webinar.
And someone had asked if we would know that they attended the webinar, and yes, we do. We have a very sophisticated program and sophisticated people behind the scene that track all of that. We even know if you went to sleep while we're going.
But the thing, when you go to get your CEU in the club, you're going to get a quiz to make sure you understood the content that was taught. It's not just a single, did I attend anymore? We want you to show that you know your stuff. Just like if you read an article in the AAPC magazine and you're going to answer the CEUs. So it helps you retain the information and really get the most out of it, but then it also helps us to prove that you were there and listening and attending, and so that's how that works. So even if you attended, it doesn't really matter. We're not like policing it based on that. When you log in, you got to answer those questions, and you can't answer them unless you watched it. So we know the length of it. So that's our way of keeping everyone on the up and up. Okay, so here's the page. This is what it looks like. There's a little countdown timer. And then this is why you want to come to this page, because you can click on these buttons to get the discounts. And I see they were very nice and even included payment plans for this 25% off. So that's pretty good. So act on that now. You got 24 hours, or 1 day, 2 hours, 6 minutes, and 46 seconds. All right. Thanks for that, guys. Okay. So our first question that came up in the chat was, how would you code a hospice patient seeking care for a URI, upper respiratory infection from physician, but not for the terminal illness? So they're a hospice patient seeking care. Go ahead.
That's
Okay. So the hospice is very unique, as you know, and it's an amazing program. And I urge you guys all to educate yourself in hospice, not just for coding, but how it's a great service to provide. What makes hospice unique is that often the patients don't have to, they don't have to leave their home. Sometimes there's hospice facilities. So you may have a provider that is coming to see the patient. So that makes a difference. But even if an acute situation arises, know that hospice is a standard rule. It's that they know that you're at your end of life. Okay. It used to be like 8 months they expected, but you could be on hospice for a year or more. The thing is they know you have a terminal illness. Okay. And with hospice and your diagnosis codes is what I'm assuming that you're kind of working with. Well, Jennifer will do the billing, but I'll do the diagnosis codes. It is still relevant. Okay, so what's your first listed diagnosis? If that's why your patient is being seen because of a respiratory infection, statistically it has to be noted, right? And that's the reason for that encounter, or even if it's not, that's what's going to take the primary focus. Now, as far as billing, that Jennifer can pick that up because after she gets done talking to whoever's behind her. No.
Oh, I'm sorry, it was so cute. My son now writes that he just finished kindergarten and he kept trying to get my attention during the last one. So he wrote me a note that he tripped on something in the bathroom and can he quietly watch TV? So gotta tell him that wasn't quiet. Turn it down.
Injury defense. I hurt myself, so can I get a treat? Or
Yep. For billing hospice, they're typically you're going through Medicare at this point when you're hospice, because typically you're older. Now in hospice, it has a specific designation. So claims going through hospice typically are through a specific provider. This happens to us a lot. Somebody's in hospice, they break something, they come into our orthopedic clinic, it's not going to get paid because we're not their hospice provider. So they typically have a specific hospice provider who provides care for them during any type of illness, even this upper respiratory infection. So you'd still code your upper respiratory infection, the reason you saw them, and it's typically done then by that hospice provider. You're not going to your primary care provider for this problem when you're on hospice. Typically you're not very mobile, or it just depends on the condition of why you're in hospice, but you're usually at a hospice home. So
right, which could be your physical home, but still,
could be.
Everything is kind of a unique entity in care for that patient. So so if you're outside of that, you're not going to get paid for the.
Most likely not. Yeah.
Still needs to be documented though and coded.
And thank you for providing that service to the patient. Yeah.
Okay, next question. What is the difference between Prophy coding and hospital outpatient / clinic coding?
Sounds like all Alicia.
Okay, I can tell you what some of that, but again, the billing is different for those. So Prophy coding is, again, your pediatrician, your PCP, your people that you're going to on a routine basis.
Is that fee for service?
Outpatient.
Fee for service? Is that what Prophy is?
Yeah, your
it can be, but it's more like what are the physicians, the providers doing? You're billing for them. I had taught once at a VA clinic, and they did both, and they kept saying Prophy and this, and so that was their division. Or were they billing for the docs, or were they billing for the overhead and what the facility was providing? So that's normally the difference. So.
Okay, well, that's a much better way of explaining it than the way I was, because I was going to go in and
I'm still needed.
Yes, you are. So much easier.
Still got it.
Yeah, you still got it.
But it is important, because they're really two different worlds, and sometimes, especially for outpatient coders, they really need to understand both worlds to know which hat they have to put on to be able to do, whatever aspect of the job they're doing. So,
and it's not always easy to switch, because I was talking to one of our other people, Tiffany, and she had asked me a question about a risk adjustment things that she's doing, and she said it just blows her brains to have to turn off like all the basic guidelines that's drilled into you when you go to have to do risk adjustment or some of these other things that she's doing. And now she's doing auditing for that, and complete capture, which is different than regular risk adjustment. And so, it can really blow your mind. And that's why when you see people looking for coders, they will say Prophy coders. That's why you see that.
You have to take a step back and look at, what are they trying to get paid for? So normally hospitals, they're not trying to get paid for the doctors. They might employ them, and and that's why some of them do Prophy Billing because they are trying to get paid for those
Right.
physician services because they pay them as an employee, but mostly they're trying to get paid for their overhead. And then you have to look at, well, how is that getting billed? Lots of times it's driven by diagnoses on the hospital side. Now
Yeah.
we got risk adjustment. So
Yep.
Right.
what they're trying to
That's
get
what
paid
I was
for
gonna.
is the amount of risk they're taking. So you
Yeah.
have to understand, and we've got a really good payment methodologies that you can get access to in the club too that Chandra had done for us. Very, very good at understanding all of those nuances.
Right.
All right, next, hydration and infusion for, I think they meant facility, not faculty. For facility coding, if a patient has hydration from 12 to 2 and an infusion of therapeutic substance from 12:45 to 1:15, what are the codes you end up with and why? And this just as an aside, we get questions like this a lot in the club. And what we normally do, because we're teachers first, is we are going to say, well, what do you think it is and why? And then we come in and we help you kind of figure out where your thinking is good and where it needs a little, adjusting. So for this, go ahead.
These are PCS codes because you're working in a facility, okay?
Yeah.
And PCS works differently than probably what most of you are used to that are encoding, unless you're an inpatient coder. PCS is a relatively new code set because it just came out in 2017. So for us to tell you the codes that you would be using for this, we're going to have to go pull the PCS stuff. I can tell you that whenever you're doing hydration infusion, because I love PCS and I talk about it quite a bit, that you time is very, very relevant, and that's why this person put this question in and put the time in. So I can't rattle it off. Your root operation that you're wanting, you're probably going to have a root operation or a category, not like med surg, but you're going to be doing measurement and monitoring as well, which starts with a 4 versus an O. And then the root operation, your third character, is going to be very specific too. And so if you would allow us, we'd like to be able to transfer this one in. It takes a little bit more time and put it in the club and maybe do a club webinar on it for you. Or put it in as a topic request. But hopefully that'll give you an idea. I can pull off my little gray cells off the top of my head because I just did measurement and monitoring lecture just like
Today,
they
right?
were usually today.
Yeah.
No, it wasn't. It was yesterday.
Oh. I thought that was today.
All the days are running together here.
Yeah.
So much content, so little time. All right, last question from the chat. Medicare billing for EKG. For Medicare patients, when billing for EKG, I use 93000, but Medicare always denied that code. Any suggestions?
And their G code? I have all my books in front of me for tonight except for my HCPCS.
Yeah.
I didn't put my HCPCS in front of me. I would assume it's a HCPCS code.
code. It's a Medicare HCPCS code, and right, you don't have a HCPCS code there. That's why you're being denied, right?
Let me look it up really fast.
Yeah. So with Medicare, sometimes they will use CPT. That's considered their level 1, but sometimes there's a little bit of way they word it in CPT they're not crazy about, so they will come up with their own code that's close. So let's see if we can find something like that. So we want to go to what? HCPCS, right?
Yeah, because I went straight to the CMS website. So let me see.
Oh, okay.
I can even find anything though. Yeah.
I was going to say, she should do CMS, so you do find a code, and then
see if I can find anything on here.
That's the CPT code. And then if you go down, scroll down, Laureen, and you can probably look at your
Screening.
Yeah, it'll tell you in the notes.
Now EKG is also a screening, and Medicare has specific screening that can be done at certain times. So that could be another reason for a denial, is if it's not medically necessary based upon the diagnosis. And a little tidbit
Uh-oh.
She's
I'm
freezing up.
losing her.
I think
Did
Jennifer.
There,
Jen-
I just found this out at the Medicare Symposium I went to. Did I freeze?
Yeah.
You did
My
momentarily.
Oh, okay.
Un poco.
All right. Well, they're going to have a virtual symposium starting in July. But all of they used to list their diagnosis codes that are medically necessary, and they're not going to include those on LCDs and NCDs anymore. So they're going to have an article in relation to it. So you have, but they will link the article. So just in case you're always going and looking at the LCD going, where's the diagnosis code? It's no longer going to be on there.
It was really nice when it was, though.
I know, but
It will
unfortunately,
link the
people
article.
used it.
So you just have to click on the article. So yeah.
So when I typed in the electrocardiogram and I said, just show me the search for HCPCS, see, these are all the ones that are available. So this one's like initial preventative exam. And I'm sure it has age differences and things like that. So that's probably the reason. So if it's Medicare patient, check these codes out as alternatives if they fit better.
And your diagnosis code, because
Your
again, everything
diagnosis
is based on diagnosis, and often, you know, EKGs, they're doing them like breading your butter on a
you're
on your bread. They
diagnosing
do them all
or
the
you're
time.
ruling out a suspected illness or condition. So it's
Yeah.
not, they're not going to say, well, my sister just had a heart attack and I have an EKG to make sure I don't have a heart attack too. Well, that's not going to fly. You know, if you have hypertension and all these other problems, then that would be one of their reasons for performing an EKG. So
Very good. All right, guys, we're a little past time. Really great webinar. I had a lot of fun. It was very easy for me because the ladies did all the answer sheets, of which I really, really appreciate. I learned a lot myself. This is where we ask you if you liked what you learned tonight. We didn't charge. We do a lot for free because we want you to get to know us, and you know, we feel that that's a good way to be. But if you want to show your appreciation, go to YouTube and like and subscribe. Go to Facebook, tell your friends about us. That's really how CCO has grown, is through word of mouth referrals, social media. We really appreciate it. So, and you might think your one little reference on your, you know, feed and Facebook isn't going to have an impact, but it does. Even if none of your friends ever take a course from us, you know, Facebook is checking algorithms, so is Google, and it helps us to be found. And we saw tonight several of our newbies found us by doing a Google search. So we appreciate that. So YouTube, Medical Coding Cert is our channel. So click the bell, become one of our bells. And then Facebook, it's cco.us. So just do facebook.com/cco.us and join us. Share our website with your social media friends. We'll greatly, greatly appreciate it. If you are involved in an AAPC chapter or some other coding organization and you need us to do a presentation for your chapter, we can do that for you. Sometimes if you're near us, we can do a local one, but we can do remote ones. And that's helped a lot of people out that are in areas where it's hard for them to get speakers. So go to cco.us and remote presentations. That was her kid coming in.
Is that your fur babies?
Now you can hear. Yeah. Well, I let TJ stay behind me, see, and because his computer's back there.
Yeah, they know it's quitting time. But thanks everyone. So please join us again next month, and we've been doing an occasional Wednesday lives, just where we get on and do kibitzing. So come join us. Did I forget anything important?
Alicia, are you doing a Dallas chapter meeting on July 16th?
I just saw that. Yeah. See, I'm going to be, Karen said, are you going to be in Dallas 7/16 for their meeting? Yes, I'm their guest speaker. I'll be in Dallas chapter. So you're 2 hours and 30 minutes away from me. So it's super easy to just drive up there and I get to go see my new grandbaby.
Yay. Well, thanks everyone, and thank you for all the team members behind the scenes making all of this come off pretty seamless, and appreciate you lovely ladies and all your hard work, and our interns and our assistants, help desk, everybody. So have a good night, and we'll see you again soon.
Thank you,
Yep.
everyone.
Happy
Bye.
learning.